with the DVT is potential development of pulmonary embolism and post-thrombotic syndrome. The annual incidence of DVT in Egypt is not known, however. It is not expected to differ from that of the United States. The annual incidence in the United States is 122 per 100,000 people. Males are more affected than females, and African Americans are more susceptible than white persons. And the incidence increases exponentially as the age advances. Comes to cause, you cannot speak about venous thrombosis as having a definite cause, but always risk factors do exist. Similar but not exactly the same, deep venous thrombosis has the same risk factors as the superficial thrombophlebitis does, but with some modifications. 100 years ago, Virchow, German pathologist, described his triad that is valid up to now, comprising endothelial injury, venous stasis, and hypercoagulable state. These risk factors may or may not occur separately or in constellation. The of vascular endothelium is important. The healthy endothelium produces vasodilators, and the fibrinolytics simply maintain balance between thrombosis and fibrinolysis. Injury to vascular endothelium, as occurs during, for example, hip surgery, tip the balance to the side of thrombosis. Has noticed that the increased use of central venous catheter and those used for medicinal and fluid administration frequently used in the ICU patients is parallel and reflects the increased incidence of upper limb deep vein thrombosis. Prior DVT put the patients at a higher risk of recurrent DVT. This risk is highest in the first 6 weeks and gradually decreases over the next 10 years. Venous compression, to be worth mentioning, is the May-Turner syndrome, in which the left common iliac vein is compressed by the right common iliac artery, poses an anatomic predisposition to venous stasis in the compressed vein and its subsequent thrombosis. Acting this way is the venous thoracic outlet syndrome. Badgett and years later, Schroeter described axillosubclavian venous thrombosis in patients who performed efforts above their head, like painting a ceiling, and gave the name effort thrombosis to that particular type of venous thrombosis. Hypercoagulable state put the patient into higher risk to develop deep vein thrombosis than other normal individuals. Each works alone or in combination can lead to deep vein thrombosis. There is constant balance between natural coagulation, anticoagulation, fibrinolysis, and antifibrinolysis. Therefore, for thrombosis to occur, there would be imbalance between these mechanisms in favor of thrombosis. More than one factor of the following interplay to bring about this imbalance. These factors are inflammation, stasis, decreased fibrinolytic activity, and activation of coagulation factors. This interplay is maximum at the site of the injury and stasis. From DVT is attributed to the concomitant comorbidity in patients who develop DVT rather than the DVT itself. This mortality reaches as high as 21% within a year following the incident DVT. The incidence of pulmonary embolism in patients with symptomatic DVT ranges from 7% to 17%. 1/3 of the patients of DVT will develop severe post-thrombotic syndrome, and 2/3 will develop milder form of this syndrome within the next 2 years. Venous gangrene, characterized by being patchy and often superficial, is rare after the wide use of modern management of deep vein thrombosis. Thrombosis usually commences in areas of relative stasis. It is thought to begin in the soleal venous sinuses or downstream of the cusps in the tibial veins. Proximal venous thrombosis without involvement of the calf vein is unusual, but still can happen. Early in the course of DVT, there may be minimal or few clinical findings. Extensive DVT may sometimes be present without signs or symptoms. Moreover, symptoms and signs such as pain and swelling can occur with conditions other than deep vein thrombosis, and therefore are non-specific. Therefore, objective studies are required to confirm or rule out venous thrombosis. Pain and swelling in the cuff, which is tense and tender, characterizes cuff vein thrombosis. Proximal venous thrombosis has, in addition to that, extension of these clinical findings into the thigh and groin. Phlegmasia cerebrodolens, the painful blue limb, has pain, pitting edema, and cyanosis due to extensive venous thrombosis of the axial deep veins with relative sparing of collateral veins, as shown in the photo of the left lower limb of that lady. Phlegmasia albadolens, on the other hand, the painful white limb, has pain, pitting edema, and pallor. In this condition, the collateral veins get thrombosed as well, with subsequent sequestration of tissue fluid, and finally, marked elevation of below the knee compartment pressure and reflex arterial spasm. Once you do suspect a deep vein thrombosis, treatment should start without delay and without waiting the results of objective testing. Just give the patient a dose of parenteral anticoagulant. If the results of objective testing came negative for deep vein thrombosis, the single dose would not harm the patient. The patient should reach the objective testing on trolley or at least wheelchair. Laboratory investigations are meant to stand on any associated condition that would affect the choice of deep vein thrombosis treatment strategy and not intended to diagnose DVT. D-dimer is a good negative test. This means negative test is helpful to exclude DVT in incidents of doubtful clinical presentation. Positive test has not the same significance as it could be elevated in DVT and many other conditions like pregnancy, malignancy, and inflammation without DVT. Thrombophilia screening should be offered to patients who have unprovoked DVT. For example, when DVT develops without prior trauma, surgery, prolonged recumbency. This is done to pick up patients who have hypercoagulable state and therefore need to have anticoagulant indefinitely. Ultrasound has revolutionized the diagnosis of DVT for the following reasons. It is readily available, has high sensitivity and specificity, non-invasive, and does not utilize ionizing radiation nor contrast medium. However, it is operator dependent. This means the experience of the ultrasound operator has a great influence on the quality of its results. Ultrasound reports of deep vein thrombosis typically read, vein is incompressible without flow inside, distended by a thrombus with loss of flow respiratory variation. This is how the normal DUPLEX examination appears. Full color flow saturation. The vein is not distended. Flow varies with respiration, Valsalva maneuver, and distal augmentation by manual cuff muscles compression. The left side photo shows the vein without, and the right side photo shows the vein during compression by the DUPLEX probe. The vein is incompressible, which means that pressure by the DUPLEX probe does not lead to collapse of the vein, opposite to what occurs when the vein segment under examination contains flowing blood and not thrombus. This photo shows no flow in the superficial femoral vein as denoted by the absence of the color saturation and the Doppler waveform, which is almost flat. Simply plethysmography records the change in the volume in relation to the venous outflow. It was used in the past before the DUPLEX gained its reliability in the diagnosis of deep vein thrombosis. Fibrinogen is converted to fibrin by the action of the thrombin, which is activating factor 2. A fibrinogen labeled by radioactive iodine is injected in a patient who is suspected to have deep vein thrombosis. This fibrinogen will get involved in the developing thrombus and emits gamma rays at a higher activity in the area of the thrombus. Such higher activity can be recorded by gamma camera. Although venography is the gold standard for the diagnosis of the vein thrombosis, its role in this respect has been supplanted by the DUPLEX ultrasound, and nowadays its role has been limited to its use in conjunction to the endovascular venous intervention. This patient was subjected to catheter-directed thrombolysis of his iliofemoral deep vein thrombosis. The video depicts the thrombus containing femoral segments during contrast medium injection into the popliteal vein through a sheath advanced under ultrasound guidance. The goal of treatment is to prevent pulmonary embolism, thrombus recurrence, which has its highest during the first 6 weeks after the incident thrombosis, and finally to decrease the incidence of the post-thrombotic syndrome, as we will see under the topic of the post-thrombotic syndrome. Anticoagulant, thrombolytic therapy, and rarely thrombectomy with or without fasciotomy. Fasciotomy can be done alone to reduce the compartment pressure and therefore improve tissue perfusion. Anticoagulant therapy is the commonly adopted way of management of deep vein thrombosis, alone or in conjunction with thrombolytic therapy. Can be achieved by parenteral anticoagulants plus vitamin K antagonist, warfarin, or by new oral anticoagulants, which are termed NWAC. Catheter-directed thrombolysis entails administration of thrombolytic solution through catheter advanced into the vein, containing the fresh thrombus under fluoroscopic guidance. We have to have an idea about the coagulation cascade to understand the areas where the common anticoagulants work. You do not have to recall this diagram, which is intended only for making things easy. You can use unfractionated heparin and vitamin K, or low molecular weight heparin and vitamin K, or fondaparinol and vitamin K. Unfractionated heparin combines with the antithrombin 3, increasing the activity of antithrombin 3 by 1,000-fold. The antithrombin heparin complex inhibits activated factor 2 and activated factor 10. Heparin is injected via venous cannula into a vein at a bolus dose of 80 units per kg, followed by 18 units per kg per hour to achieve activated partial thromboplastin time of 1.5 to 2.5 times the control. Being the primary side effect of all anticoagulants, its incidence with unfractionated heparin is 5%. In this event, heparin should be discontinued. Heparin antidote, protamine sulfate, be given by IV route in a dose of 1 milligram for each 100 units of heparin at a maximum dose of 50 milligram over any 10 minutes period. The second important side effect of heparin is the HIT, heparin-induced thrombocytopenia, which is antibody-mediated phenomenon develops during the second week of commencement of heparin administration. It is treated by replacing heparin by fondaparinol or beta-pyridine, which is called Thrombex infusion. Many brands under the class low molecular weight heparin have similar modes of action to that of unfractionated heparin, and with the following differences. More bioavailability, therefore have longer half-life. Predictable elimination are given through subcutaneous route at weight-adjusted dose, therefore allow outpatient treatment of venous thromboembolism, but they cannot be monitored by activated partial thromboplastin time. All the oral anticoagulant means that it is the oldest and still being used to now for more than 50 years. It prevents gamma carboxylation of vitamin K dependent procoagulants, factor 2, 7, 9, and 10, as well as anticoagulants protein C and S. Its anticoagulant effect starts to appear in 36 to 72 hours after its regular daily intake, and its effect starts to wane in similar periods after being discontinued. That's to say, it has delayed onset and delayed offset, representing one of its major disadvantages. It's given orally once daily at a dose which is adjusted to have INR anywhere between 2 and 3. Usually, the starting dose is 5 mg or lower in old patients and in patients who have low body mass index. INR 2 to 3 represents narrow therapeutic window. The patient can easily get above 3 or below 2. Getting above 3 puts the patient at risk of developing bleeding, and conversely, getting below 2 puts the patient at risk of thrombosis recurrence. This can furtherly be elucidated in the following graph. In clinical practice, only in 44% of time, the patients could have their INR within the therapeutic range. This means in most of the time, the patient's INR is either below or above the therapeutic range. Many drugs, as well as certain foods, can increase or decrease the binding of warfarin to plasma proteins and therefore increase or decrease the free active form of the drug. Consequently, it requires frequent INR monitoring, a frequent dose adjustment. Bleeding, as stated earlier, correlates with INR above 3 and represents a challenge to control because of the slow offset of the warfarin action that cannot be simply reversed by the warfarin discontinuation alone and necessitates, in most instances, to give the patient fresh frozen plasma or prothrombin complex concentrate. The use of vitamin K antagonists are severe liver disease, active malignancy, first trimester of pregnancy, intracranial hemorrhage within 3 months, active GIT bleeding like esophageal varices and peptic ulcer. New oral anticoagulants which have the suffix "pan" like rivaroxaban and apixaban are oral direct factor 10 inhibitors, whereas dabigatran is direct factor 2 inhibitor. Anticoagulant therapy does not dissolve the thrombus. It does provide the optimal environment for the natural fibrinolysis to act on the thrombus, a process which takes time until the thrombus resolves. For that reason, anticoagulant therapy should be given over a minimum period of 3 months. In extensive DVT with severe congestive symptoms, endangers limb perfusion, or more recently, to decrease the incidence of post-thrombotic syndrome, catheter-directed thrombolysis has been advocated to bring about quick thrombus lysis and preserve the function of the valves of the deep system. Principally, catheter is advanced usually through the popliteal vein under ultrasound guidance into the thrombus. The lytic agent is perfused through this multiple-site home catheter into the thrombus. Check venogram is done at the end of the procedure to assess the results and the need to put stent. Venous thrombectomy is rarely performed nowadays. The result is dismal and being inferior to less invasive procedure. It has given its place to minimally invasive techniques like the endovascular venous intervention.